This video is recorded for educational purposes only. The procedure has been performed by a qualified trained surgeon in a sterile and controlled environment. It is not meant for diagnosis, treatment, or self-care. Do not try this at home.
Assalamu alaikum. Today, the case under discussion is a right-sided non-functioning pyonephrotic kidney in which the percutaneous nephrostomy was performed 3 to 4 weeks back, and the patient came out of sepsis, and now after doing the differential functions, the kidney is non-functioning, so we are performing simple laparoscopic nephrectomy. As mentioned in my previous lectures on difficult pedicles, this is one of the most difficult pedicles that I have ever faced while performing laparoscopic surgeries. You saw that there was dense adhesions of the kidney with the liver, so those have been released, and now there are some adhesions of the ascending colon, so these are being released. Extensive mobilization of the ascending colon in this case is really of importance, and the reason is that the more we mobilize the colon, it will be easy for us to identify the ureter and the psoas muscle. Here, the psoas muscle, the ureter, and the gonadal vein are identified. However, the structures are so much inflamed that we are really very in trouble to mobilize the renal system from the midline structures. The midline structures on the right side are the gonadal vein, the inferior vena cava, and another structure, don't forget the name, is the duodenum, which is very fragile. IVC, remember, is directly connected to the heart, so an injury can lead to severe morbidity or even mortality. And the duodenum is also very fragile, very much sensitive to thermal injuries and serosal injuries, which can later on lead to delayed complications and with a high mortality and morbidity. So the ureter has been identified. You can see how much hard it is. It is inflamed and difficult to manipulate. However, we have found it, so that's good. So we mobilize it a little bit, and then we try to create a window. However, the inflammation is so much that the exact mobilization that we really want is not possible to achieve. So now comes the structures towards the midline. As we are mobilizing the lower pole of the kidney, we move towards the hilum. So here I find that it is one of the difficult pedicles, and the reason for that is recurrent inflammations, recurrent episodes of infections, and then pyonephrosis, and then the percutaneous nephrostomy tube itself. So here you can see that as the I was trying to dissect more towards the pelvis rather than the duodenum in order to avoid any perforation of the duodenum or even the serosal injury. I went into the renal pelvis. So it is really good that at least we now know where the renal pelvis is, and it's better to perforate the pelvis rather than perforating or injuring the duodenum. So what we do is that I placed a Veress needle into the system to drain it even more if there is any pus. But even after taking out the pus, the kidney is not really decompressed in a great deal. So, and the second thing that happened is that after removing the needle, we found that there is bleed from the puncture site. It may be from inside the kidney, or it may be from the capsule, or it may be from the gyrotous fascia. However, I have successfully controlled it with a bipolar forceps. So now the task is to mobilize the pelvis from the duodenum. Remember, the problem with the pelvis, we still have to deal with the vein and the artery. The artery in this case may be thrombosed and very small, but the vein is usually very fragile in such cases. So as the renal pelvis is perforated, we may perforate the renal vein. So the risks are there. So what I'm doing is that I'm trying to mobilize the structure which is attached to the renal pelvis, and then I go to the lower pole again in order to follow the ureter. So that ureter will lead me to the pedicle. So it is not a routine kind of nephrectomy. At times I go to mobilize the upper pole, and then I go to the lower pole, and then I come to the area of the pedicle. So I'm modifying my basic technique of performing nephrectomy. Remember, safety is always the priority. So the indication for conversions are usually the topmost is the safety, and the second indication is that if you don't make any progress up to 15 minutes or 20 minutes, or if I'm very generous, I would say 30 minutes is the maximum. So if we are not making any progress for 30 minutes continuously, it is really better to convert the procedure to open. Since we are making progress here, albeit very minor, I would say microscopic progress, but still we are progressing. So I'm deciding to keep on going, keep on digging around the pedicle. Now I go to the upper pole in order to find some plane where the duodenum and the hepatic flexure can be dissected away from the pelvis. So at this point, I'm really very sure that it won't be possible to complete the procedure laparoscopically. I'll have to convert it at some point for the safety of the patient. So if I have decided to convert it, since it is not an emergency conversion, there is no injury to any structure, there is no injury to the vessels, to the pedicle. So we will try to dissect things and take advantage from the laparoscopic magnified view, so that when we open the patient, it will be just a matter of dealing with the pedicle. So now the hepatic flexure is completely mobilized away from the kidney. Again, I would grade it as a progression. That's why I'll keep on going. Meanwhile, there is perforation in the pelvis, but luckily we have drained all the pus from the kidney. However, the tip of the percutaneous nephrostomy tube can be seen popping out, and it is good as well, because now I will take it as a landmark to know where the structures are. However, after mobilizing this tissue, we will see that the duodenum will be seen clearly, and some of the some of the soft tissue or the connective tissue around the duodenum is of course densely adherent to the renal pelvis. So while dissecting the duodenum from the renal pelvis, we'll keep our instruments tipped towards the renal pelvis rather than towards the duodenum. And I will not use any energy source, because that can lead to, duodenum is extremely sensitive, mind you, to thermal injuries. I would say it can attract energy from far-flung areas. So you have to keep the energy level of the device to the minimum, or you have to, if at all you are using, you have to use it very much away from the lumen of the duodenum, and it is better not to use any energy source near it. So I think it is extremely near to the area where we are dissecting or cutting, so I will opt not to use any energy source and use the sharp instrument like scissor. So we are making some progress, and in the meanwhile I have instructed my surgical team to, there you can see this may be the renal vein, but we are not sure. Posteriorly, this one, it may be the renal vein, but we are not sure. And I have seen that if it is the renal vein, it is very much fragile and very much adherent. So I have asked my surgical team to prepare for the conversion of the case, and since it is not an emergency conversion, it is just for dealing with the renal pedicle safely. So we have got time, and so I'm trying to mobilize the kidney from all around while the team is preparing, so that when we open or convert the case to open, the renal pedicle will be the only thing to deal with. But mind you, if a procedure is difficult laparoscopically, that doesn't mean that it will be easy in open. What happened in this case particularly, the renal vein was so fragile that after applying the crushing clamp on the renal vein, it actually avulsed, perforated, and then avulsed from the inferior vena cava. So the kidney was in my hand, and it was bleeding. However, it was promptly controlled with the vascular clamps, and then it was dealt with successfully. So this is the scenario. Thank you very much for watching.